of HIV. And so what you're seeing here on the y-axis is CD4 T cell concentration. So these are the primary cells that the virus is infecting, these T cells that are, if you will, the quarterback of the immune response. And then the x-axis shows time, typically in months after infection. And so initially what we see is a rapid rise in virus antigen in the blood. And this corresponds with some kind of shaky up and down growth of the CD4 T cells that are designed to fight the infection. But eventually, after a period of time, the virus antigen becomes undetectable in the blood. And what's happening here is the virus is actually replicating intracellularly for long periods of time, and so and it's a slow burn, and so again you don't see much antigen in the blood, but what we do see is this gradual drop in CD4 T cell count as the virus replication starts to kill these T cells, and then eventually this, and then up here you can look at the clinical presentation. An acute infection, you don't see anything yet, or the individual may experience flu-like symptoms. Here is chronic lymphadenopathy phase, where because there's so much inflammation and a vigorous immune response, the individual has swollen lymph nodes, typically in the neck. And then there's some subclinical immune dysfunction in this phase here, as the virus starts to build up and then eventually starts to be released into the bloodstream. Here you see the human body trying to produce anti-HIV antibodies to control the virus, but they don't do anything, right? Because the virus is mostly intracellular at this point. And then eventually the immune response, the antibody response drops off just as the virus is leaving the cells into the bloodstream. So there's no neutralizing antibody, or very little neutralizing antibody, to attack the viruses. The progression of infection, is basically paraphrasing what I just showed you in the graph, but individuals have an increased susceptibility to opportunistic pathogens like pneumocystis, pneumonia. The T helper cells decrease below 200 or 100 per cubic millimeter. I think that the number was actually revised to 200, so it was revised upwards a little bit. But huge amounts of viral loads that are produced, and then other opportunistic infections take place. The individual loses weight and has persistent fever and persistent swollen lymph nodes and diarrhea and Kaposi sarcoma, even dementias. The viruses invade the brain. Without treatment, the individual will usually die. 3 views of AIDS. This is pretty interesting. The first view is from Robert Gallo, who is one of the scientists that was credited with first isolating and discovering HIV. But that's a huge controversy, and I should leave it to you to look into that. But Gallo was accused of some improprieties early on, and really I think Luc Montagnier's group at the Pasteur Institute deserved all the credit without giving any to Gallo, but in the sense that these guys first discovered HIV and first isolated it and then sent their virus to Gallo's lab to confirm, and Gallo was in the United States. Gallo was believed to have just stole the virus, I guess, I don't know, and then claimed that he also isolated the same thing. But the viruses were too similar between the two labs, and so it was kind of shady what happened. But Gallo somehow tried to piggyback in there and get the Nobel Prize with Montagnier. But his view is that infection by HIV is sufficient to cause AIDS. And Montagnier's view is that HIV may be harmless in the absence of other cofactors. So I don't know what those cofactors are. I kind of lean, even though I just disparaged Gallo a little bit, I kind of lean towards his view that if you're infected with HIV, that's typically sufficient to have your immune system crash and then to develop AIDS. Whereas Montagnier thinks it's possible that HIV can be harmless if you just lived in a plastic bubble, maybe. I don't know. And then there's a real far out version of the view of AIDS by Duesberg, who's a molecular biologist at Berkeley, and I don't know whether he's still there, but just kind of an old nut job. And then Kerry Mullis, who discovered and earned the earned the Nobel Prize for PCR, and they believe that HIV is too silent to be the cause of AIDS, so they consider it to be a much maligned bystander. And again, I don't know. But this box right here kind of summarizes my point of view that greater than 50% of HIV infected persons progress to AIDS. There's no strong evidence that there's any other infectious agent but HIV. So, again, HIV sort of opens the door and allows a lot of other pathogens to come in. And many times those are what kill the individual. But HIV in and of itself can get into your brain and do a lot of different things that can lead to death. So I'm not sure what Montagnier and Duesberg and Mullis are thinking. I do know that Duesberg and Mullis are really weird people, though, from personal experience with both of them. Some of the anti-HIV strategies include education, and that's easy enough because it's sexually transmitted or primarily sexually transmitted. It can also be transmitted through blood transfusions and so forth. But in the general population, because it's sexually transmitted, pamphlets and sex education and condom distribution, things like that can actually have a great effect. It's not highly contagious, and so again, what we mean by that is that you'd still have to have sex with an HIV positive person at least 1,000 times or more before you actually got infected. Statistically speaking, obviously it could happen to you just one time, but usually it takes a lot of prolonged exposure. Anyway, so the education is really key in this particular case. It's harder to be educated about respiratory pathogens. You can know everything you want to about respiratory pathogens and still, have somebody sneeze one into you at in a hospital ER. Chemotherapy is also important as your anti-HIV strategy. And so in this particular case, one of the things we worry about is mutant selection resulting in resistance. So again, you got to hit the viruses hard and in multiple spots, or else the virus with its high mutation rate can develop resistant offspring. So if you can suppress replication, you can diminish the capacity for mutation. And that's where we're kind of at right now, is suppression, not, outright attempting to kill things. It's just slowing them down so that the immune system can keep up with them. So one class of drugs that we use for HIV are the RT, or reverse transcriptase inhibitors, and they can be non-nucleoside or nucleoside. So nucleosides are drugs that look like DNA bases, and so this guy actually looks like AZT actually looks like the actual nucleotide thymidine. And so in this particular case, the difference here is that there's the 3' hydroxyl is removed, and in its place is a 3' azide group. So when this thing gets added to the growing DNA chain, the next phosphate group, the next 5' phosphate group from the next DNA will try to bind to the azide and can't, and so you get chain termination. So imagine the polymerase is going along laying down bases. If it grabs this base and tries to stick it in there, this azide prevents the phosphodiester bond from forming, and so the chain is terminated and the virus can't replicate. The problem is, you're relying on this analog, this nucleoside analog to look enough like the actual chemical and be specific enough for this particular enzyme that it doesn't interfere with replication in the host cells, like natural replication. And that's honestly what happened in many cases, was AZT would get into the bloodstream and go into your kidneys and then cause severe blockages in the ability of kidney cells to replicate, and that would cause kidney failure in many cases. The non-nucleosides are chemicals that don't look anything like nucleotides, but have the affinity to bind to, in some weird way, reverse transcriptase, and by binding to it, it kind of changes its active site and prevents it from doing its job. And so in this particular state, the non-nucleoside chemical binds to that, changes the receptor, and then makes the enzyme unable to produce viral DNA. Another approach that's been used successfully are protease inhibitors. As I already talked about, the virus needs proteases in order to cleave its polyproteins into these different forms. And if it can't do that, this polyprotein stays stuck together, and neither of these has any function. And so again, we can try to knock out HIV through the addition of protease inhibitors. And so that's typically what's done then in this anti-HIV strategy called HART, highly active antiretroviral therapy. So HART often includes 2 nucleoside analog RT inhibitors and a protease inhibitor. You could also use nucleoside analog RT inhibitors and non-nucleoside. But the point is that these are cocktails of drugs. And so the cocktails are designed to suppress growth, but also minimize the formation of resistant mutants, because you're hitting the viruses in multiple different locations. So some of the problems with developing an HIV vaccine, Dr. Fauci had talked about, we're going to have a vaccine. He was working hard on it in the 1990s and promised everybody a vaccine that never came. And I'm not knocking him, but it's a difficult process, especially with a virus like this. Shouldn't be a difficult process for SARS-CoV-2, but it is a difficult process for HIV. In this particular case, macrophages may be infected by 2 routes. And so here's HIV, here's GP120 binding to the macrophage. So HIV GP120 binds to the macrophage CD4 antigen. The virus, however, is opsonized by anti-GP120 antibodies. And so in this particular case, imagine the virus gets coated with antibodies. That allows this macrophage to more efficiently eat the HIV particles and take them in. The problem is that's kind of what HIV wants. It wants to get in here and replicate. And so if you're creating a situation where the body is producing antibodies, that's actually going to enhance the uptake of HIV into a susceptible host cell. So again, not only does HIV infect T cells, but it also infects macrophages. So that's a vaccine problem, right? You don't want to making antibodies actually is counterintuitive. So some of the reasons for population polymorphism include the fact that HIV is a retrovirus, and that its reverse transcriptase is really low fidelity, meaning it purposefully seems to be designed to make mistakes. The funny thing is that most of those mutant progeny will go extinct. They won't be able to infect anything subsequently because their RNA is so badly mutated. However, some of them will be perfectly mutated to the point where they become the next successful generation. And if you're an HIV positive individual, you're producing tens of billions of virus particles every day. So there's high likelihood that a few of those are going to be a royal flush and cause even more infections. So retroviruses use host cell RNA polymerase in the nucleus to replicate their genome, but POL2 has a pretty decent error rate as well. So POL2 can actually make some mistakes in replicating the virus. HIV genome is about 10,000 nucleotides. Every new virus has at least one mutation based on these issues here, particularly with the low fidelity of the reverse transcriptase. Because of the mutation rate of reverse transcriptase, every new virus, statistically speaking, will at least have one mutation. And that just leads to the production of a mutant horde of viruses that go into the cell and then come out different than whatever went in. So every possible single mutation arises daily. So again, the HIV that infects a patient is very different from what's seen by the time AIDS appears. And again, that's also a vaccine problem here because the virus is constantly changing. So your vaccine target is a moving target. and that becomes a huge problem.